Greetings and a warm welcome to all the dignitaries present here. I'm Rimpa from Clernet, serving as the allocated session assistant to ensure a seamless experience. Clernet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for the doctors. It is with great pride that Clernet serves as the digital partner for this event. And the focus of today's session is geriatric anesthesia. Now, I would like to invite Dr. A.L. Meenakshi Sundaram, Sir, a distinguished anesthesiologist and academic leader. Sir has served as Dean and DME at several government medical colleges, including Theni and Stanley Medical College, Chennai. He is a former National Vice President of Indian Society of Anesthesiologists and has held key positions, including Governing Council member, President, and State Secretary of ISA TamilNadu State Branch. To proceed, over to you, sir.
Thank you. Thank you, Clernet, for that inaugural speech. Now we request Dr. Munian, our President, ISA Puthukkottai City Branch, to offer his presidential address.
Good evening all. I am Dr. K. Munian, President, ISA Puthukkottai City Branch. On behalf of ISA City Branch, Puthukkottai, I welcome all the faculties, our academic chairman, moderator, and the delegates for the online webinar. Every week we are conducting online webinar in the name of Puthukkottai Bhudhan. Today we are conducting 25th episode of second edition of Puthukkottai Bhudhan. Today we are going to talk about geriatric anesthesia, which is a rare specialties. We are expecting more complications from the aged individuals. Geriatric anesthesia requires careful consideration of age-related physiological changes, comorbidities, medications, interactions. What are the key aspects included in period of assessment? Comprehensive evaluation of medical history, physical status, and cognitive function, which is more important in aged individuals. Optimization of chronic conditions like hypertension, diabetes, and cardiac disease. And also we have to evaluate the medication history, which will guide us to reduce the polypharmacy and potential drug interactions. What are the anesthetic considerations in aged individuals? Pharmacokinetic changes, altered drug interactions, distributions, metabolisms, and excretion due to age-related changes in body composition, liver functions, and renal system. And pharmacodynamic changes increases the sensitivity to anesthetic drugs, opioids, and other sedative drugs. And hemodynamic stabilities, careful management of blood pressures, cardiac output, and volume status. Pain management, which is very important. We have to reduce the opioid requirements, for which we have to need multimodal approach to minimize opioid and other sedatives to minimize the side effects. Regarding anesthetic techniques, as much as possible, we have to consider regional anesthesia in the form of epidural, spinal, and peripheral nerve blocks where needed. General anesthesia also indicated in some conditions which needs careful titration of anesthetic agents and pharmacodynamics and pharmacokinetics. Post-operative care, close monitoring, vigilant observation of the potential complications such as respiratory depression, cardiac issues, and cognitive changes. Pain management, continued multimodal approach to minimize the opioid use and other side effects. Early mobilization, which is essential in age-related to avoid any DVT and early recoveries. What are the key takeaway message from geriatric anesthesia? Geriatric patients requires individualized anesthetic care, considering the unique physiological changes and comorbidities. Multidisciplinary approach, including perioperative optimization of careful anesthetic management and post-operative care, are essentials. Anesthesiologists should be aware of the potential for increased sensitivity and anesthetic and opioid in geriatric patients. Our faculties are interested to share their experience with all of us. It's over to you, sir. Thank you, sir.
Thank you, Dr. Munian. Now I request Dr. Kannan, our secretary, to offer his secretary report.
Good evening all. I am Dr. Kannan, Secretary ISA Puthukkottai City Branch. Successfully, we are conducting 25th webinar of second edition of Puthukkottai Bhudhan today. Today our topic is geriatric anesthesia. I welcome all our eminent speakers to our webinar. Our President Dr. Munian has given a short lecture about geriatric anesthesia. Thank you, Dr. Munian sir. Last week, July 2nd, we have conducted 24th webinar of second edition of Puthukkottai Bhudhan successfully. Last week topic was USG guided regional anesthesia chest wall blocks. We have divided the topic into 3 subtopics. First one is innervation of chest wall, was done by Dr. M. Anita, postgraduate, Coimbatore Medical College, Tamil Nadu. Second subtopic is anterior chest wall blocks, was done by Dr. T. Maithili, Senior Assistant Professor, Coimbatore Medical College, Tamil Nadu. Third subtopic was posterior chest wall blocks, was done by Dr. Narmada Youngstri, Associate Professor, Coimbatore Medical College, Tamil Nadu. Our moderator was Dr. Selvakumar Kingsley, Chief Anesthesiologist, Thiraviyam Orthopedic Hospital, Nagarkoil. Last week, around 820 delegates have attended our webinar. And one more thing, and important one, our economic chairman, Dr. A.L. Meenakshi sir, is going to contest in ISA National President Elect 2025. Kindly, all anesthesiologists support him and elect as president. Thank you all. Thank you, sir.
Sir,
Sir, you are muted, sir.
sir, you have to unmute, sir.
Actually, Dr. Ganesh Prabhu, our moderator, is finding it difficult to switch on his video and audio because of some internet connectivity problem. So we will start and he will be joining. And today we are very happy to have the Velammal Institute of Medical Sciences, Madurai. That is our parent branch, TamilNadu, is hosting this webinar. And the junior most faculty, Dr. Ashwini Elango, is a resident of Velammal Medical College. And she is going to deliver a lecture. I think it may be the first time for her. She has done her MBBS in Pondicherry Institute of Medical Sciences, and she is pursuing MD in Velammal Medical College, and she is interested in playing badminton. So I don't know whether it is a ball badminton or shuttlecock. And coincidentally, Dr. Lavanya is also interested in playing badminton. Who taught whom, I don't know. Whether it is the PG taught associate professor or associate professor instead of teaching anesthesia has taught badminton, I don't know. But she is interested, and she is interested in reading books. She will read all books except the textbook, I think. So she is interested in reading all textbooks, and her hobbies are dancing, not singing. And the best part, sometimes this Puthukkottai Bhudhan will become a matrimony, and this young doctor is waiting to get married, and minimum 850 people will be seeing this webinar. And I wish her all the best in her future also. And 2 associate professors are participating in our webinar today. That is a great thing, because we used to say the 3 great ladies from Velammal Medical College are participating in this. And Dr. Ramadevi is an associate professor in Velammal Medical College. And madam has a lot of credit to her. She has done her MBBS in Puthukkottai Medical College, and she has done MD in Madurai Medical College, probably under Ganesh Prabhu, because Ganesh Prabhu born, brought up, serviced, retired from Madurai Medical College, I think. So in the same department, it is very rare to see people like this. Same way, Madam Ramadevi Madam is working for 10 years in Velammal Medical College, and she has delivered lectures in state and national level conferences. Actually, Velammal hosted the conference, anesthesiology conference once. That is the best part of it. And Madam is interested in pain medicine. So I have to ask her spouse whether she is relieving the pain of family or not. That we have to verify. And madam is interested in gardening, trekking, and travel. So I wish her all the best. And it will be followed by another associate professor, Dr. Lavanya, who has coordinated very well for us for this webinar. She only arranged all the photographs, details, whatever we ask, with ever smiling face and enthusiasm. She has coordinated this, and she is also an associate professor in Velammal Medical College. And madam has great publications. She has published both the people, Dr. Ramadevi and Lavanya, even that PubMed Index journals they have published. And she's also a faculty in ISACON national conferences and state conferences. And she's interested in extracurricular activities. Again, as I said, it is playing badminton. So like Dr. Ashwini Elango. So Dr. Lavanya is a former Ashwini Elango, and Ashwini Elango is a future Lavanya as far as ball badminton is concerned, I think. And so to coordinate, even to managing one lady is very difficult. And to group these three, Dr. Ganesh Prabhu has taken the role as a moderator. When I joined anatomy as a first MBBS student, when I joined anatomy, people asked me, what is a GP? I said it is globus pallidus. Then everyone congratulated me. This boy has answered very well. And after I joined anesthesia, I was asked, what is GP? I said globus pallidus. They said it is wrong. GP is always Ganesh Prabhu. So it is before the Christ, after Christ, like that. Before anesthesia, it is globus pallidus. After anesthesia, it is Ganesh Prabhu. Because as I said, he studied, joined, promoted, and retired from Madurai Medical College. Those are every brick of Madurai Medical College anesthesiology department knows Ganesh Prabhu. And actually, Ganesh Prabhu helped many postgraduates. See, at the same time, simultaneously, he will be anesthetizing 7 or 8 cases with his juniors. So everywhere he used to fly from one nursing home to another nursing home, even without a helicopter, even in the car, he goes like that. And TamilNadu is having 2 people who served as Secretary TamilNadu ISA, President TamilNadu ISA, Governing Council Member National ISA, and Vice President National ISA. Only 2 people are from Tamil Nadu, achieved all these 4 achievements. And you should be interested who are these 2. So one is introducing the other. So one is me, another is Ganesh Prabhu. So Ganesh Prabhu was a state secretary, state president, and national governing council member and a national vice president. So with this introduction, till Dr. Ganesh Prabhu unmute himself, I request Dr. Ashwini Elango to talk on her subject, on complications, but postgraduate has taken the topic as complications. So only complications will come at the end. So I think we can go ahead with the physiological changes in, usually we used to say physiological changes in pregnancy, but this time it is physiological changes in geriatric anesthesia. I request Dr. Lavanya, associate professor, to talk about physiological changes first. So once we are convinced about physiological changes, we know how to anesthetize. So once Ramadevi anesthetizes it, the post-operative complications will be managed by Dr. Ashwini Elango. Now it is over to Dr. Lavanya.
Yes, sir. Good evening, everyone. Thank you, sir, for your warm introduction. And I'm Dr. Lavanya, Associate Professor in Department of Anesthesia. First of all, I would like to thank Dr. Meenakshi Sundaram, sir, and Puthukkottai ISA City Branch, and our HOD, Dr. Ganesh Prabhu, sir, for giving me this wonderful opportunity. And sir, am I audible?
Yes, yes.
Yes, sir. And my topic for today is about the physiological changes in geriatrics. So it is estimated that about 45 to 50% of the geriatric surgeries accounts for the total surgical population in majority of the advanced countries. So there are so many definitions which are available for geriatric population. The most accepted one is the chronological age of 65, which are considered as geriatrics. Hence, it is imperative that an anesthesiologist must know the impact of aging on physiology and pharmacology, as well as the impact of comorbidities and the composite effect of all these changes on perioperative outcomes. According to American Society of Clinical Oncology classification, we classify the geriatric population as young old, who lies between 65 to 80 years, and older old, who are above 80 years. Next, moving on to the biology of aging. So these are the 5 key elements of human aging process. One is that genes, lifestyle, and then other one is chance, nutrition, and environment. Under genes, we have multiple mechanisms which leads to the defects like oxidative damage, DNA damage and repair, shortening of telomeres, mitochondrial senescence, and malfunctioning of proteins. Next, we'll move on to the theories of aging. We have 4 theories. One is the evolutionary theory, molecular theory, cellular theory, and systemic theory. Evolutionary theory states that aging occurs due to the accumulation of mutation and disposable somatic cells, which is required for reproduction. And next is the molecular theory. As seen in the previous slide, molecular damage and changes in the genetic expression are the reason for aging. Third one is your cellular theory, where we have telomere shortening, free radical damage, wear and tear of the cells, and apoptosis. And under systemic theory, which includes neuroendocrine alteration and decline in the immune function. And this is about the theories of aging. Next, we will look into the physiological changes system-wise. First is the cardiovascular system. So under cardiovascular system, the aging process is associated with the primary as well as the secondary changes. Here, the primary changes occurs mainly in the blood vessels, and the secondary changes occurs in the heart. So this is the morphological changes in the heart followed by the functional changes. So under morphological changes, we have reduction in the number of myocytes and the sinus node cells, as well as the conduction fiber density is also reduced. But the LV wall thickens, and the functional changes are there will be a reduction in the contractility, as well as the beta adrenergic sensitivity is also reduced. But the myocardial stiffness and ventricular filling pressure all increased. So all this will contribute to the arrhythmia as well as the diastolic dysfunction in elderly people. This slide shows about the 2 major structural effects which occurs in the blood vessel. One is the atherosclerosis as well as the next one is the arterial wall thickening. Both this will lead on to increase in systolic blood pressure as well as the pulse pressure, and there will be increase in aortic root as well as there will be a increase in the pulse wave and reflected pulse pressure. And both this will increase the aortic impedance and LV loading as well as the wall tension. And finally, we'll have a left ventricular hypertrophy. All this will lead on to prolonged contraction of the left ventricle with a delayed relaxation. And then finally, we'll have diastolic dysfunction as well as systolic dysfunction. I'm sorry. Yes, sir. And this slide shows about the increase in pulse pressure in elderly. Here, younger adults will have a pulse pressure or variation of about 40 millimeters of mercury. As age advances, there is an increase in the pulse pressure even above 80 millimeters of mercury. Here, functionally, arteries become very less responsive to both the vasoconstrictors as well as the vasodilators due to endothelial changes. Framingham Heart Study shows that their systolic BP is increased by 5 millimeters of mercury per decade until the age of 60, and then by it increases to about 10 millimeters of mercury every decade, but the diastolic is not much changed. So these all changes will lead on to alteration in the ventricular vascular coupling. And in elderly geriatric patients, the incidence of diastolic dysfunction and heart failure is increased with aging. So other predisposing factors for diastolic dysfunction could be hypertension, IST, left ventricular hypertrophy, and cardiomyopathy, as well as valvular heart disease. All this might contribute to it. So, what happens in diastolic dysfunction? There will be a reduced left ventricular compliance. Along with that, there will be an increase in left ventricular pressure. All this will lead on to retrograde pulmonary venous congestion and then finally pulmonary edema. So, the clinical picture here is identical to that of the systolic dysfunction. Hence, we need to differentiate between the systolic function as well as the diastolic dysfunction as the treatment option differs. So, the diagnostic choice for this is mainly by echocardiogram. And then moving on to the most important part, why arrhythmia is poorly tolerated in elderly people. As we have seen before, there will be a reduced ventricular compliance and increased afterload. This will lead on to compensatory prolonged myocardial contraction, which occurs at the expense of early diastolic time. So the contribution of atrial kick is very important to maintain the forward flow as well as the heart rate. So we need to maintain a sinus rhythm in elderly geriatric people. And about the autonomic nervous system. So there will be an increased sympathetic nervous system activity. Normally, the function of beta receptor is to increase the heart rate, venous rhythm, as well as systolic BP, and that is how it preserves the preload. But in elderly people, we have reduced beta receptor response due to alteration in the signal transduction. Hence, during stress and exercise, the elderly heart is more susceptible to heart failure as there won't be any increase in maximum heart rate as well as the ejection fraction. So this is why geriatric patients will be having beta blocked heart. And next is the anesthetic implication of cardiovascular changes which occurred in geriatrics. First one is the blood pressure liability. Here it occurs mainly due to the vascular stiffening, and here during intraoperative period there will be a hypotension due to this BP liability, along with that which is exacerbated by our use of vasodilatory drugs, anesthetic drugs, as well as dehydration. The second is the dysautonomia of aging. This occurs mainly due to impaired beta receptor responsiveness, which limits the ability of the heart to increase the cardiac output by increasing heart rate. And next is the left ventricular hypertrophy, which occurs secondary to the vascular changes, which leads on to the diastolic dysfunction. And most of the geriatric patients are dependent on the atrial kick for the forward flow. But due to all these cardiovascular changes, the atrial kick will be lost. And the most common arrhythmia in geriatric is atrial fibrillation. And other prevalent cardiovascular conditions include fibrosis of the cardiac conduction system, as well as the calcific aortic stenosis, calcific aortic valve, and aortic stenosis. Then moving on to the respiratory system changes in geriatric patients. Anatomically, the upper respiratory tract will have loss of buccal fat, with the patient might be edentulous, and the patient will have reduced cervical spine extension with the joint stiffness. All this will contribute to difficulty in mask holding, ventilation, as well as performing laryngoscopic and intubation. And regarding the changes in the lower respiratory tract, due to altered collagen network, the chest wall becomes stiffer and the lung tissue loses its intrinsic elastic recoil, and there'll be an increased alveolar air space like emphysema. All this will increase the physiological dead space. And then about the musculoskeletal changes, it includes muscle loss, diaphragmatic flattening, kyphosis, rib calcification. All this will lead on to reduction in the respiratory muscle strength, and there will be an increase in the work of breathing. Next, about the physiological changes in the respiratory system, about the volumes. This picture compares the normal young adult lung with the aged lung. Here, as geriatric patients are not able to take an adequate deep breath, their inspiratory reserve volume, expiratory reserve volume will be reduced, but the tidal volume here is preserved. All this will lead on to slight increase in FRC with a reduction in the vital capacity, but the total lung capacity remains the same. And here the forced expiratory volume at first second is also reduced. And the most important part of respiratory change in geriatric is the significance of closing capacity. Closing capacity is nothing but the sum of the closing volume as well as the residual volume. As age increases, the closing capacity also increases. Here, once we see the graph, at age 45 years, at age 45, the closing capacity will be equal to that of FRC in lying position. But at 65 years of age, the closing capacity is higher than the for FRC even at supine position. So what does it mean is that in fit young adult, the closing capacity is always lesser than FRC. So the airway closure doesn't occur during normal breathing. But in elderly people, where the small airways closure occur even before the completion of expiration, this will lead on to air trapping, atelectasis, hypoxia, as well as shunting. So the result is that during lithotomy position and Trendelberg position, atelectasis occurs faster due to increase in the closing capacity. So these are all the effects of increased lung compliance in geriatric patients. So there will be an increase in VQ mismatch, impaired gas exchange, and there will be a reduced pulmonary reserve with increased alveolar arterial oxygen gradient. So these are all the anesthetic implication of respiratory changes in geriatric. First one is the reduced ventilatory response, which occurs due to hypoxia, hypercapnia, as well as the mechanical stress. So this even occurs secondary to the reduced central nervous system activity. And second one is aspiration. Geriatric patients are more prone for aspiration due to the weak pharyngeal muscle, and there will be a reduced cough reflex with a reduced mucociliary transport. In that case, we have to choose neuraxial technique whenever required. And if we are performing general anesthesia, adequate reversal has to be done before shifting up the patient. And the fourth one is the geriatric population are more prone for, third one is the geriatric patient are more prone for atelectasis. This occurs due to increase in the closing capacity and increased work of breathing with a reduced vital capacity. So the treatment here is early ambulation and chest physiotherapy, incentive spirometry, which has to be followed from preoperative period, and it has to be continued in post-operative. And the geriatric population are very much sensitive to respiratory depressant drugs like benzodiazepines, opioids, and volatiles. So try to avoid those drugs. And so these changes compromise the usual protective response against the hypoxia after anesthesia and surgery. And finally, we need to screen the geriatric population for obstructive sleep apnea too, because as they might be having the reduced genioglossus tone. Next, about the most important system is nervous system. Structurally, there will be a cerebral atrophy with a reduced gray matter and white matter, which is secondary to the neuronal shrinkage. There will be a gyral atrophy with an increased ventricular size too. And talking about the neurotransmitters, we'll have a reduced dopamine, acetylcholine, norepinephrine, and serotonin with a reduced cerebral blood flow too. All this may predispose the patient to geriatric syndromes like Alzheimer's and Parkinson's disease. And about our neuraxial changes. So there will be a reduced epidural space, permeability of dura is also reduced, and the volume of CSF, myelinated fibers, and the intestine cell distance in peripheral nerves, everything is reduced in geriatric population. So that is why elderly population is more sensitive to neuraxial and peripheral nerve blocks. And moving on to next, renal changes in geriatric population. About the anatomical changes, the renal mass is reduced by about 30% by 80 years of age, and the renal blood flow is also reduced by 10% per decade after 40 years, and the functioning glomeruli is reduced, but the remaining glomeruli will swell up. So there will be a progressive decline in the creatinine clearance too. But the serum creatinine is normal as the geriatric population muscle mass is reduced. So the important factor here is the serum creatinine is a poor indicator of renal function with aging. So dosage adjustment has to be done for renal clearance strength. So which is considered as a good indicator for renal function is that GFR calculation. That is the best indicator for renal function in aging. And these are all the functional changes in geriatric population in renal system. One is that there will be reduced production and responsiveness of renal angiotensin system, and structurally we have renal vascular dysautonomy, which will lead to here the vascular reflexes will be attenuated, which protects us from the hypo as well as hypertension. And the second is the senile hypoperfusion occurs. Here there will be decline of GFR of about 1 ml per year after 30 years. And third is there will be a tubular dysfunction. Here, the renal capacity to conserve sodium is reduced. And added to that, the older patients will take less salt. So they must be having less thirst response. So they are at risk for dehydration as well as the sodium depletion. And the fourth is that we have medullary hypotonicity, where the antidiuretic effect is very much less. So the concentrating ability of urine is also reduced. And then the tubular frailty. Here, the renal tubular cells are more susceptible to hypoxia or nephrotoxicity injury, and it will take a longer time for recovery. And the geriatric population will have a diminished ability to handle the salt load. So they might end up in fluid overload. So fluid status is very important during the perioperative period. Next, moving on to the hepatic changes in geriatric population. So the anatomical changes is that liver volume is reduced by 20 to 40%, and the hepatic blood flow is also reduced by 10% per decade after 40, and the metabolism as well as the clearance of the drugs is also reduced by the liver. Hence, the application here is we need to decrease the maintenance dose of our anesthetics. So this slide will depict the physiological changes as well as the pharmacokinetic consequences. So one is that there will be a decreased total body water, and comparatively there will be increase in body fat too. Once the body fat increases, there will be an increase in volume of distribution as well as the THAP. The lean body mass, how we calculate is that the mass between the muscle as well as the visceral organs. So the lean body mass is reduced in geriatric population. This will increase the plasma concentration and volume of distribution of hydrophilic drugs. And the serum albumin is also reduced. Once the albumin is reduced, there will be increase in free fraction of highly protein bound acidic drugs. And the other factor is that there will be increase in alpha-1 acid glycoprotein. So the free fraction of basic drug is reduced. So this is about the physiological changes and pharmacokinetic consequences. Next, moving on to the musculoskeletal changes in geriatric population. So patients will be having sarcopenia with a reduction in the subcutaneous fat. Here the application is that it will be very difficult to insert an IV line even though it is seen very clearly, as there won't be any fat to hold the line, and the muscle strength is also reduced. And the osteoarthritis, patient will be on osteoarthritis and osteoporosis. So padding is very much important in order to prevent them from nerve injury. And the geriatric population will be having increased chance of fracture during transportation inside theatre. So we need to be very careful while positioning the patient in the theatre as well as shifting the patient to PACU. And moving on to our geriatric syndrome. First is the dementia. So it is stated that about 6 to 8% of population above 65 years might be suffering from Alzheimer's disease. So there is a dictum that pre-existing dementia in the surgical patient is a strong predictor of post-op complications, greater hospital stay as well as the cost, and it is one of the independent predictor of 30-day mortality. So it is important to document the cognitive deficit in the preoperative assessment chart. So what are the issues of dementia for an anesthesiologist? It is the patient might be agitated inside the theatre, and post-op emergence might be there, and perioperative morbidity must be there. And this is how we assess the patients about the criteria for the main scoring of dementia. So this is called the mini mental status examination. Here what we do is we can check the patient's orientation by asking simple questions of year, season and all that. And we can assess their recall, memory, and then attention, calculation, and then about the language. So the total score is about 30. Normally, we say the patient is having the normal cognition by the score of about 24. If the score is less than 24, we can classify the patient as mild, moderate, and severe cognitive dysfunction. So next geriatric syndrome is Parkinsonism. So we have a triad of resting tremor, bradykinesia, and muscle rigidity. The incidence of Parkinson's disease above 65 years of age is about 3%. So mainly this occurs due to destruction of dopaminergic neurons in substantia nigra. Here, our concern is that people with Parkinson's disease must be dealing with increased risk of aspiration due to postoperative pharyngeal muscle dysfunction. And then in that case, we need to continue the anti-Parkinson's regimen on the day as well as the post-op period. And the monoamine oxidase inhibitors will interact with the opiates, and there will be exacerbation of rigidity too. So please avoid phenothiazines, diprophenons, and metoclopramide in geriatric patients with Parkinson's disease, as these are all dopamine receptor antagonists which might exacerbate the symptoms. And regarding the polypharmacy, most of a geriatric patient will be on multiple drugs. So polypharmacy is one of the significant risk for drug interaction during the perioperative period. And the next geriatric syndrome is frailty. Frailty means susceptible person to fall. It is the loss of physiological reserve that makes a person more vulnerable to disability during and after stress. So we have a clinical syndrome which got the components of frailty are mobility, poor exercise tolerance, muscle weakness, weight loss, and then malnutrition, as well as the unstable balance. So this is the criteria we use to define frailty. So according to this criteria, patient with a weight loss of more than 5% of body weight in the last year are considered to be frail by weight loss criteria. And if the grip strength is reduced, then they are considered as frail. And if the patient feels exhausted frequently within a day or more number of days in a week, then they are considered to be frail. And then if the physical activity is very low, they are considered to be frail. And if the patient is asked to walk for a short distance and it is timed, and they are considered to be frail if they are slow walkers. That is, if they are not able to cover within 6 to 7 seconds for walking of about 15 feet, then they are considered to be frail. So the main thing here is there will be an increased risk of adverse health events and outcomes if they are considered to be frail. And next is delirium. So the incidence is about 10% after major elective surgery like cardiac surgery and hip fracture surgery. So delirium is nothing but the syndrome characterized by acute onset of variable and fluctuating changes in level of consciousness. So this is how we this is the criteria we use to assess the delirium. So one is that the patient must be having acute onset of mental status changes and inattention. The both must be there. Along with that, any one of the remaining two can be there. Either the altered level of consciousness or the disorganized thinking. So this has to be documented in the post-op period. So the most important factor in the post-op period is the depression, which has to be addressed very carefully. So these are all the predisposing factors which might lead on to delirium. One must be dementia, sensory loss, multiple comorbidities, advanced age, alcohol, and malnourishment and all that. And the precipitating factors inside hospital could be any acute illness, fecal infection, surgery, anesthesia, pain, sleep deprivation, and fluid or electrolyte disorders. So what is the consequence of delirium is that there will be a higher risk of post-op mortality with the cognitive decline and the risk of falls and pressure ulcers. And finally, as usual, our aspiration risk. Then moving on to the important part, that is autonomy, that is the mental competence to give a consent. So many of our geriatric patients must be having dementia, depression, hearing difficulties, stroke, which will interfere with the ability to make an independent decision. In such case, surrogate must be giving the consent, can give the consent. And about the nutrition. So here, malnutrition has led to an increase in mortality as well as morbidity. And then about the depression. The incidence is about 10% for more than 65 years of age. In that case, we have to continue the antidepressants during the surgery as well as in the postoperative period. Next, moving on to the immobility. Most of the geriatric patients will be on prolonged bed rest and they must be facing problems like ventricular atrophy, hypovolemia, orthostatic intolerance, which has to be kept in mind while performing regional technique, and there will be a reduced pulmonary function, which might lead on to post-operative pulmonary dysfunction, and the chance of DVT is also highly encountered. So in order to prevent that, we need DVT scanning to be done before before surgery. and about dehydration, which might lead on to infection, pneumonia, as well as upper respiratory tract infection with a post-op respiratory complication. So dehydration has to be corrected before taking up any case. And alcoholism plays an important predictor of post-op pneumonia in non-cardiac surgery too. And about the thermogenesis, elderly are more prone to hypothermia due to the lower body metabolism, vasodilatation of skin blood flow, as well as there will be reduced capacity of thermogenesis. So we need to maintain the body temperature, as the effects of hypothermia might lead on to angina, myocardial infarction, hypoxemia with a ventricular tachycardia. So, as well as during spinal anesthesia, there will be a higher level of blockade, which is associated, if there is a higher level of blockade, which is associated with the increased magnitude of hypothermia too. And other concerns in geriatric population is that trauma, where the cervical spine trauma is twice likely in elderly due to the falls and cervical instability. And other iatrogenic complication could be adverse drug events with a reduced functional decline too. And we need to ask the elders about the chronic pain management. That is, if the patient might be on arthritis, bone pain, musculoskeletal pain too. So they will be on chronic painkillers. So we need to elicit a proper drug history before taking up any case. So let's look into the factors affecting the pharmacological response of elder patient. As seen before, the albumin is reduced with the increase in alpha-1 glycoprotein, and about the body composition, there will be a smaller central compartment with the increase in the serum concentration of the bolus drug. And the drug, regarding the drug metabolism, the hepatic and renal clearance will be altered with the degradation pathway affected, and that was going to affect the drug clearance too. And about the important part, that is the application of a clinical pharmacology of anesthetic drugs. So to start with the propofol, which is an induction drug which we use most often, just we have to reduce it by 40 to 50% due to the decreased clearance and increased volume of distribution, and it has got increased brain sensitivity too. And next is the etomidate, which is our favorable choice of induction agent. So this has to be reduced due to reduced clearance and increased plasma concentration. And about the thiopentone, here the dose reduction should be done as there is a decrease in the initial volume of distribution. And regarding the inhalational agent, MAC is reduced by 6% per decade after 40 years, hence the dose has to be reduced. And regarding the muscle relaxants, the availability of neurotransmitters as well as the neuroreceptors will be reduced with aging. With this will result in prolonged neuromuscular blockade too. So, while using succinylcholine, it may have a prolonged effect on set time and duration due to reduced muscle flow as well as the reduced cardiac output. The vecuronium has to be used very carefully due to reduced clearance, and so the dose adjustment has to be done. And about the opioids, all opioids are twice as potent in elderly patients due to reduced clearance, so which might result in severe hypoventilation and apnea, especially morphine, which has increased volume of distribution and reduced clearance. So dose has to be adjusted. Fentanyl has increased sensitivity, so the dose is reduced. So this is about the clinical pharmacology of anesthetic drugs, and about the ketamine, which is rarely used due to fear of post-operative delirium. So these are all the changes about the elderly patient regarding the physiology. So our main special perioperative concerns for elderly people is that we have to maintain their independence after the surgery like before, and we have to assist for early recovery, and we have to avoid any functional decline. Thank you.
Thank you, Dr. Lavanya. Am I audible, Meenakshi?
Yes, sir, you're audible.
Yes, sir.
Yes. Good evening, all of you. Sorry for my delayed entry because of some technical problems. I am Dr. Ganesh Prabhu, HOD Anesthesia, Velammal Medical College, Madurai. Our two associate professors will be contributing for today's webinar, and one of our postgraduate will be talking. I think Dr. Lavanya has finished on our changes in the elderly people apart from the adult. So she has dealt it very nicely. And crux of her topic will be was the changes, physiological changes. What are the changes in each system, cardiovascular system, respiratory system, and CNS, and also liver and liver and kidney. So in the cardiovascular system, the main problem is there may be morphological changes and functional changes in the both heart, blood vessels as well as in the heart. So thereby producing systolic dysfunction as well as diastolic dysfunction. In the respiratory system, there was gross anatomical changes and physiological changes in the elderly. Mainly the closing volume will be more than the FRC. So the geriatric patient will be easily going for hypoxia. So we should be very careful in anesthetizing the geriatric people. In addition, there are changes in the CNS, that is post-operative cognitive dysfunction and also post-operative delirium. So we should be carefully dealing the elderly people. And also there are changes in the liver and kidney. So all these concerns should be taken up very well. I think Dr. Lavanya has dealt it very nicely. And our next speaker will be Dr. Ramadevi. He will be talking on the preoperative evaluation of the geriatric patient coming for TURP surgery and also the anesthetic management. Over to Dr. Ramadevi. Ramadevi.
Yes, sir. Thank you for your introduction. So I thank the Puthukkottai Bhudhan branch and Dr. Elango sir for giving me this opportunity. And I congratulate them for successfully and consistently conducting this meeting. So topic is so can you see my screen?
Yes, ma'am.
Yeah. Topic is on anesthetic management of transurethral resection of prostate in elderly patients. So this is my lecture overview outline. So I will explain about the prostate gland anatomy and a comprehensive geriatric assessment, particularly in geriatric patients assessment and preoperative consideration in TURP, investigations, anesthesia of choice, goals of anesthesia and intraoperative consideration, irrigation fluid of choice, sorry, TURP and its complication, followed by conclusion. So first coming to anatomy. So relevant anatomy. So prostate gland, it weighs around 20 grams and encircles the urethra as it emerges from the base of the bladder. So usually the patient will present with the symptoms when the prostate weighs above 60 grams. It comprises glandular and non-glandular components enclosed by a fibrous capsule. So the normal prostate tissue become compressed against the capsule and it is called as a surgical capsule. Any violation in this prostatic capsule may lead to absorption of large volume of irrigation fluids. So on the prostate gland, blood supply is mainly from inferior vesical artery, a branch of internal iliac artery, and the venous drainage is by prostatic plexus that drains into internal iliac vein. So the nerve supply to the prostate it mainly arises from prostatic plexus, which originates from inferior hypogastric plexus that carries both sympathetic and parasympathetic fibers. Sympathetic fibers from T11 to L2 and parasympathetic fibers from S2 to S4. So pain fibers from prostate and prostatic urethra and bladder mucosa originate from sacral nerves S2 to S4. And the pain signals from the bladder distension travels with the sympathetic fibers and origin from T11 to L2. So before going into TRP, so we have to assess the comprehensive geriatric assessment. This is a multidisciplinary and multidimensional assessment and management in the geriatric patients. So first is a timed up and go test, that is tuck test, that is performed. Normally the patient will have less than 10 seconds to get up from chair and go walk for a short distance and come back and sit in the chair. If it is greater than 20 seconds, it carries more post-operative complications. So it is a screening tool usually used by oral pre-anesthetic checkup in geriatricians. Before going to comprehensive geriatric assessment, this timed up and go test is performed. Coming to next is a frailty assessment, followed by evaluation of comorbidities, functional status, neurocognitive function, sensory impairment, nutrition, medications. This I will discuss in separate. So first is a frailty. So geriatric populations will have a multi-system physiological deteriorations. That is, already their reserve will be very less when compared to that is. And they are more susceptible to stressors, and the clinical consequence of the stressors will be more. So this carries a clinical frailty score. The score is of 9-point ordinal scale that assess the degree of frailty and address the planning for the surgery. So the clinical frailty scale of 3 is considered as the patient will manage well and may not need additional care. Whereas a score greater than 6, the patient is considered as moderately frail and may require proper preoperative optimization and careful post-operative planning. Next is the assessment of neurocognitive impairment. So in geriatrics, mainly the post-operative delirium and post-operative cognitive dysfunction is more common. So the early easy tool to assess the patient's cognitive function is mini mental state and mini cognitive test. Here the patient is asked to recall 3 items. So there is memory recall test and asked to draw a clock, that is clock drawing test, that is used as a distractor. So patients scoring of 2 or less may experience cognitive impairment and may need additional workup. Coming to cardiac evaluation, the patient, all the geriatric patients may need to be evaluated for any cardiac because atherosclerosis and the cardiac dysfunction, that is left ventricular systolic and diastolic dysfunction is more common in them. So it is mandatory to have ECG and echo prior proceeding to any surgery in those patients. So we'll assess the functional capacity by metabolic equivalence. If it is greater than 4, the patient has a good metabolic functional capacity of oxygen consumption. Whereas if it is the patient has any musculoskeletal disorders, OA knee, we won't be able to evaluate the patients. For them, the patient has, we have to evaluate for further investigations of cardiac. So the revised cardiac risk index is adopted. It contains 6 independent predictors to stratify this risk in those patients. Coming to pulmonary evaluations, the geriatric populations will be having more prone for post-operative pulmonary infections because they already have a reduced pulmonary reserve. COPD, asthma, lung infection, tuberculosis are most common in those patients. And preoperative spirometry is not mandatory. And because in those patients with unexplained dyspnea or exercise tolerance, intolerance, on those patients COPD and asthma with unknown degree of airflow obstructions, spirometry can be done. Otherwise, it is not mandatory to evaluate. Coming to renal function, so there is a decline in renal reserve in geriatric population, and associated hypertension and diabetes may further impair the functioning nephrons. So careful management of hypovolemia, hypotension, and electrolyte balance, and the nephrotoxic drugs medication has to be avoided in this patient. So nutrition assessment is the most important one, as these patients are more prone for urinary tract infections, slow wound healing, surgical site infections, and pneumonia. For this mini nutrition assessment is available. So albumin value, that is a surrogate marker of malnutrition. If it is less than 3, that indicates a malnutrition. Next, coming to polypharmacy. So most of the people will be having many drugs per day. There is more than 5 drugs per day. Usually they'll be having. It is related to negative outcomes such as functional impairment, adverse reactions, and long stay in the hospital, readmissions. So in order to prevent this, we have to perform an accurate medication review, that is in a preoperative settings, in order to avoid adverse post-operative outcomes. So for this, Two criteria are available: screening tool of older person's prescription, that is TURP, and screening tool to alert to right treatment criteria. It's available. So their pharmacy, the drug has to be reviewed before giving any type of anesthesia. And the perioperative use of anticholinergics and benzodiazepine has to be avoided in those patients. So it is a comprehensive geriatric assessment chart. Here, first we are performing the TURP test to assess the functional status, that is followed by the Mini-Mental scoring, that is communication issues linked to sensorium and cognitive alteration, followed by physical examination to focus on related organ changes, that is age-related organ changes, followed by risk stratification. So we have various stratification. Usually we'll use ASA, physical status classification system, then acute physiological and chronic health evaluation, physiologic and severity score for enumeration of mortality and morbidity, and Goldman cardiac risk index. So we have many Android apps. So using the smartphones, we can download this app and assess, get the assessment in the geriatric population, the POSM scale, so Edmund Frailty scale, geriatric depression scale. So these are the risk stratification scales available. So coming to preoperative consideration in TURP surgery. So mainly the patients will be elderly and will have a coexisting disease like diabetes, hypertension, COPD patients will be there. How to preoperatively optimize according to the disease condition of this patient. And again, the patient will be on long-term diuretic therapy and they will be depleted with electrolytes and dehydrated. So we have to have a proper fluid management preoperatively. And again, because of urinary tract infections, urinary obstruction, long-standing urinary obstructions, they will have an impaired renal function. So that has to be optimized. So investigation that is performed prior to surgery. So complete the total count. So in case of infections, there will be rise in total count and hemoglobin. As the hemoglobin blood loss is anticipated, hemoglobin has to be optimized prior to the surgery. Renal function test, serum electrolytes, blood sugar has to be, HbA1c has to be done. And liver function test along with albumin, that is a surrogate marker of any malnutrition. And coagulation profile, chest X-ray, ECG, echo, blood grouping and typing. So coming to ASA standard monitors, all the basic monitors are connected. In case of the patient condition, clinical condition is not, we have to go for invasive monitoring. So in this ECG, NIBP saturation temperature monitoring is mandatory in these patients as hypothermia. The irrigation fluids is used and also the cool operation theater. So you have to monitor temperature in the geriatric populations as their thermoregulatory mechanism is depressed. So goals of anesthesia and TURP surgery. So to achieve hemodynamic stability, to ensure safe and proper positioning, there is mainly lithotomy position in those patients during the surgery, and to obtain adequate level of blockade in case of regional anesthesia, and prevention early recognition of TURP syndrome, and followed by post-op analgesia. These are the main goals of anesthesia and TURP surgery. So in top consideration, mainly positioning, the lithotomy positioning has to be done. Proper padding has to be done in the at the level of legs, and the legs has to hang freely. And the fluid management, normally the normal saline is used intraoperatively, and fluid management based on the patient's body weight has to be calculated, and temperature monitoring has to be done. So anesthetic technique of choice. So there is a way options of anesthesia available: spinal anesthesia, epidural, caudal, and general anesthesia. Out of this, spinal anesthesia is anesthetic technique of choice in TURP surgery. So here, the patient in the sitting position at the L3, L4 space, we are giving local anesthetic hyperbaric bupivacaine around 2 to 2.5 ml. So in order to, it will achieve a blockade of around 10. So level of blockade is around T10 that has to be done. So above this level is not needed because any extraperitoneal bladder perforation may not be recognized when the blockade level is higher. So midline approach. So this ligaments will be ossipate. We can go for paramedian lateral approach to epidural and subarachnoid space because of the midline calcification. So apart from this paramedian approach, approaching L5S1 interspaciatilus approach, it's the largest intervertebral space to avoid tissue distortion caused by dorsal vertebra. So positioning of geriatric patients to perform neuroaxial block is challenging because of the dorsal kyphosis and difficulty to flex hip and knee joint because of arthritic changes and calcification of ligamentum flavum with age, difficult needle placement and advancement, decreased intervertebral space with age due to presence of osteophytes. This was a technical difficulty during performing the regional anesthesia. So coming
Madam, your internet is unstable. Madam, please check. Madam, your internet is unstable. Dr. Rimpa, you please help her,
Yes.
or else she can only talk by switching off the video.
She's not there in the meeting as I can see, sir.
Now, no, I think she might have been left and she tried re-entry.
Okay, sir.
It may be a possibility.
Yes, sir.
There is a possibility. She has left because internet connectivity was poor.
Yes, sir.
I think moderator, sir.
Yes.
You can go for that next person, sir. She can continue.
Meanwhile, I will read out one question in the chat box. Huh?
No, it can be at the end, sir.
Okay.
It can be at the end. So you can go to the third speaker again. Madam can come and complete.
So I can ask the third speaker. Huh?
Yes.
Ashwini, Dr. Ashwini.
Yes, sir, I am there, sir.
Are you ready now?
Yes, sir.
Please share your slides.
So is my slides visible?
Okay, and now
Yes.
because of the some technical problem, Dr. Ramadevi has left out. She will be shortly coming in. Meanwhile, we will be listening to Dr. Ashwini's lecture on post-operative complication in geriatric anesthesia. Over to Dr. Ashwini.
Good evening, one and all. I am Dr. Ashwini Elango, pursuing first year post-graduation in Department of Anesthesia in Velammal Medical College. I would like to thank Dr. Meenakshi Sundaram sir and my HOD Dr. Ganesh Prabhu sir for this opportunity. Post-operative complications can be broadly classified as respiratory, cardiovascular, neurological, and locomotor. In case of respiratory complications, it has been classified as ventilatory depression, hypoxemia, carbon dioxide retention, aspiration, pneumonia, and atelectasis. Ventilatory depression, it's mainly because the administered drugs can release circulating mediators, which can in turn cause bronchoconstriction, and there is altered mucociliary function promoting the retention of secretions. There is decreased surfactant productions and inhibition of alveolar macrophage activity. These all can lead to ventilatory depression, and post-operative residual curization is another kind of mechanism. There is strong evidence regarding the beneficial use of low tidal volume strategy since the action of inflammatory cytokines are low and there is low instance of pneumonia. Hypoxemia, condition where the arterial oxygen tension is below the normal. It could be because of problems associated with oxygen delivery system, problems with the patient, increased airway resistance, inhibition of hypoxic pulmonary vasoconstriction, and condition causing poor delivery of oxygen to tissues. And there is also increased demand of oxygen post-operatively. Post-operative carbon dioxide retention is also known as hypercapnia or hypercarbia, where the body fails to remove the CO2. This is because of various factors like impaired ventilation, respiratory muscle weakness, mainly because of the anesthetic drugs and impaired pain medication. Hypercapnia can manifest with symptoms from mild dyspnea and somnolence to severe symptoms like confusion, respiratory depression, and even coma. Causes of retention include impaired ventilation, respiratory muscle weakness, use of drugs like opioids, surgeries of the chest and abdomen, and consequences could be respiratory acidosis, neurological effects, cardiovascular complications like arrhythmia. Management. The proper management include adequate oxygenation, ventilation, treat the underlying cause, and pain management. The collapse of lung tissue is called as atelectasis, and it's most common because of post-operative. And cause of atelectasis can be divided as obstructive and non-obstructive. The main symptoms include non-productive cough, hypoxia, and respiratory failure. The physical examination can show reduced movement of the affected lungs, dullness or percussion, and absent breath sounds. In this, you could see the Silhouette sign, whereas the loss of borders there separating the two cavities, and the crowding of vessels and tracheal shift is present in the second picture. Management include post-operative therapy of bronchodilators, physiotherapy, cessation of smoking, and antibiotics if needed, and identify pre-operatively risk factor patients like having COPD, asthma, bronchiectasis, smoking, and doing early interventions as soon as possible for these kind of patients. Using 100% oxygen at induction, CPAP can increase the margin of safety for oxygenation before intubation and PEEP. Performing recruitment maneuvers, increasing the vital capacity by inflating to 40 centimeter water for 10-15 seconds, and then followed by 15, and then increasing the desired tidal volume to be achieved before returning to the standard settings. And other strategies used in case of ventilation is like post-operatively prone position, because this can improve the perfusion, and kinetic beds that can reduce the incidence of collection of secretions, and using chest physiotherapy, bronchoscopy, mucolytic, these all helps to clear away the secretion and enhance the ventilation process. Use of surfactants and fluorocarbons, this can reduce the surface tension as well as the lung recruitment has been enhanced. Pneumonia. Post-operative pneumonia is usually of a main concern, especially it is because of hospital-acquired or ventilator associated pneumonia. Risk factors because of immobility, chronic immobility, and changes in patients' usual bacteria and weaken immunity system from the illness. And usually it occurs within 48 to 72 hours of endotracheal intubation and could be maximum within 30 days. And the post-operative pneumonia criteria include rales or dullness on or percussion on physical examination of the chest, and new onset of purulent sputum and change in the characteristic of this patient, and isolation of organism from the blood culture, isolation of pathogen from the specimen obtained by transtracheal bronchial brushings or biopsy, or chest radiography showing signs of pneumonia like infiltrates, consolidation, cavity, and any of the following like new onset of purulent sputum, isolation of organism from blood culture, isolation of pathogens from the specimens, isolation of virus or detection of the viral antigen, and diagnostic single body antibody titer IgM or fourfold increase in IgG or histopath evidence of pneumonia. Any one criteria needs to be fulfilled to establish the diagnosis. It's important to actually isolate the organism, because organisms usually isolated within first 3 days are Staph aureus, Streptococcus, and Haemophilus influenza, but whereas later organisms are more resistant organisms like Pseudomonas and Acinetobacter baumannii, and early initiation of treatment is essential for the geriatric population. Aspiration pneumonia. Aspiration will result in chemical pneumonitis. It's usually the risk is increased in case of patients with reduced GCS having prolonged immobilization and underlying neurological deficits, esophageal strictures, and post-abdominal surgeries. As soon as aspiration has been suspected, try to initiate the Manchester respiratory intervention that includes ICOF strategy, incentive spirometry, cough and deep breathing exercise, oral care with the help of chlorhexidine mouthwash, and understanding the practices, and get out of the bed immediately, quick mobilization, and head and elevation of the bed. Cardiovascular complications has been classified as myocardial infarction, congestive heart failure, cardiac arrest, arrhythmias, and hypotension. Perioperative MI is the most common cause of morbidity and mortality in geriatric patients. The two mechanisms are acute coronary syndrome and imbalance between the myocardial oxygen supply and demand postoperatively. Excessive sympathetic activity induced tachycardia and hypertension can wear off the stress and leading to the rupture of the already formed plates. Increased postoperative procoagulant activities, reduced anticoagulant activities, and increased enhanced activity of the platelets. These all are responsible for MI. So the diagnosis can be made by rise in troponin plus any of the following: ischemic signs and symptoms, or diagnostic criteria which shows new pathological Q waves or new wall motion abnormality or fixed defect in echo. And the immediate treatment of MI, as all know, MONAT as M stands for morphine to relieve the pain, O for oxygen to combat the ischemia, N for nitroglycerin to enhance vasodilation, aspirin to decrease the platelet activity, and thrombolytics, anticoagulants, and stool softness to reduce the stress, and sedatives to give reassurance to. Congestive heart failure, where the inability of the heart to supply the sufficient oxygenated blood for the body, it could be left or right ventricle. And left heart failure is usually associated with metabolic inequivalence like orthopnea, exertional dyspnea, fatigue, cyanosis, whereas right heart failure is usually associated with ascites, enlarged liver, spleen, JVP, elevation, etc. And the treatment includes use of medications like ACs, ARBs, beta blockers to decrease the pressure, diuretics to release the fluid buildup, digoxin to increase the strength of contraction, and in case of surgery, valve replacement, CABG, implanted cardioverters, ventricular assist device, and it could even lead to heart transplant in case of severe disease. So cardiac arrest. Sudden cardiac arrest is due to the sudden cessation of the cardiac activity due to hemodynamic collapse. The main risk factors associated are a case of CAD, inappropriate pain management, previous cardiomyopathy. The reliable signs include absence of pulse, unconsciousness, no respiratory movements, and can be associated with seizures. First, initially try to rule out the reversible causes of cardiac arrest. The 5H stands for hypoxia, hypovolemia, hyperkalemia or hypokalemia, acidosis, and hypothermia. And 5Ts, pulmonary or coronary thrombosis, tamponade, tension pneumothorax, and toxins. So initiate as soon as possible CPR and resuscitate. The arrhythmias associated with the post-operative geriatric population is sinus tachycardia, atrial fibrillation, flutter, accelerated junction rhythm, paroxysmal SVT, and ectopic atrial tachycardia. Hypotension is mainly because of inadequate intraoperative fluid management and not properly replacing the ongoing surgical losses, blood, and the enhanced sympathetic blockade residual activity because of spinal or epidural anesthesia. The causes include MI, valvular heart disease, drug-induced sepsis, cardiac tamponade, pulmonary embolism, and iatrogenic sympathectomy. Management include treat the cause, oxygen supplementation, and enhance the fluid management with the help of bolus of crystalloids, replace the blood loss, correct the electrolyte imbalance and acidosis, use of vasopressors, atropine, glycopyrrolate, epinephrine, and steroids. The neurological complications mainly in case of geriatric population is post-operative delirium and post-operative cognitive dysfunction. The post-operative delirium is characterized by change in mental status, characterized by prominent disturbance of a patient and reduced clarity of awareness of the environment, which is acute in onset and develops within hours and days and tends to fluctuate during the course of the day. So the clinical features usually are disorganized thinking, alterations in the consciousness, cognitive deficits, hallucination, psychomotor disturbances, and lethargy. The main important cause for post-op delirium is polypharmacy, alcoholism, sedatives, opioids, anticholinergics. Apart from this, this is the main characteristic in case of patient is age older than 65 years, cognitive impairment, and sensory deficits like visual or hearing. And when there is ICU admission, because of this, it could lead to psychosis and inappropriate pain management and sleep deprivation and long-term immobility. The management of post-operative delirium is correction of the metabolic electrolyte disorders, perioperative continuation of neuropsychiatric medications, and decreased exposure to the delirium-triggering drugs and agents causing delirium, and pain management adequately, better sleep environment, and treat the underlying precipitating cause. Post-operative cognitive dysfunction, it is usually deterioration of the intellectual function presenting as simple impairment, or even it could lead to memory or concentration impairment. It is not usually detected until days or weeks after anesthesia, and it could be even lasting for several weeks. It's actually made with the help of neurophysiological testing and evidence of greater memory loss that shows as compared to other geriatric populations of the same age. The predisposing factors are due to increasing age, lower level of education, pre-existing cognitive impairment, perioperative hypoxemia, hypotension, hyponatremia, and post-operative infections, and prolonged it's because of increasing age. Hypothermia, elderly are more prone to hypothermia because of the lower body metabolism, vasodilation of the skin blood flow, decreased thermogenesis capability, and the above can lead to shivering, increased metabolic demand, slower drug metabolism, and increased risk of myocardial ischemia. It could be prevented by using warm solutions, blankets, and maintaining the OT temperature adequately. Thrombosis refers to the formation of clot in deep veins. The most important signs associated with DVT is Homans and Moses signs. And also skin changes could be usually visualized. And other clinical symptoms are fever, unilateral pain and cough. It could lead to pulmonary embolism. Management usually employed is adequate hydration, deep breathing exercise, adequate analgesia, and early mobilization. And mechanically, it could be graded elastic compression stockings, intermittent pneumatic leg compression, and chemicals like drugs, heparin unfractionated, low molecular weight heparins, warfarin, fondaparinux, aspirin, dextran. The above can be employed. Thank you.
Hello. Thank you, Dr. Ashwini. You have done a good preparation and you delivered a good lecture. Next, I call upon Dr. Ramadevi. Dr. Ramadevi, are you ready now?
Yes, sir. Yes, sir.
Dr. Ramadevi?
Yes,
and
sir.
you can proceed where you stopped.
Yes, sir.
Please.
Sure. So advantage. Yes, sir. Is the screen visible?
Yes, madam. Yes.
Yeah. Okay. Right. So advantage of regional over general anesthesia. So detection of early signs of TURP syndrome, bladder perforation, and ideal for elderly patients with the respiratory problem. In regional anesthesia, will avoid polypharmacy and also reduces blood loss, and good early post-operative analgesia, reduced incidence of post-operative DVT, and neuroendocrine immune response is better preserved in regional anesthesia when compared to GE, and lower cost. So the general anesthesia, normally it is indicated in those patients who have a contraindication for regional anesthesia, poor cardiac reserve, when the systolic dysfunction is there. So in those patients, we will go for general anesthesia. Here the polypharmacy is a disadvantage because already the renal parameters will be elevated and the stress response to induction will be exaggerated. And during intubations, there will be hypertension, tachycardia. That may increase oxygen demand. And again, the difficult face mask seal because of atrophy of muscle around the lips and edentless mouth may affect the bag and mask ventilation difficult. And also, arthritis of temporomandibular joint and cervical spine may difficulty in extension of neck may pose a difficulty airway in those patients. So coming to irrigation fluid that is used in TURP surgery. So the ideal irrigation fluid that should be transparent, electrically non-conductive, isotonic, non-toxic, non-hemolytic when absorbed, easy to sterilize and inexpensive. But no such solutions fulfills all this criteria. So irrigation fluids available is mainly what we are using is the glycine 1.5%. That is hypotonic solution with the osmolarity of 220, 175. The other irrigation fluids available is normal saline. mannitol, glucose, cytol, urea. So out of this, glycine is used commonly because it is more or less close to our serum osmolality of 290. Our normal serum osmolality is around 280 to 300, whereas the glycine has around 220 milliosmol per kg. Whereas distilled water has a 0 osmolality, it should not be used as an irrigation fluid. So factors affecting the amount and rate of fluid absorption. So it depends upon the size of gland. That is the rule of 60. So when the size of the gland is more than 60 grams, more fluid absorption will be there. And if the hydrostatic pressure of irrigation fluid is greater than 60 centimeter of water, there will be more fluid absorption, irrigation fluid absorption. And duration of procedure greater than 60 minutes may also lead to increased fluid absorption. And height of irrigation fluid from the pubic symphysis, if it is above 60 centimeter, it may also affect the absorption of irrigation fluid. So calculation of absorbed fluid. So it is calculated using a formula preoperative serum sodium and divided by post-operative serum sodium multiplied by ECF. ECF is nothing but 20% of body weight minus ECF, the extracellular fluid. So normally if there is greater than 2 liters of fluid absorption, the patient will elicit symptoms. So because of fluid absorption, there may be a hypervolemia, and that may lead to hypertension, bradycardia, increased capillary leak, ventricular failure, or cardiovascular collapse. And also because of hyponatremia and hypoosmolality, patient may exhibit signs of cerebral edema. And because of glycine that is used intraoperatively may lead to hyperglycinemia, hyperammonemia, that may cause visual disturbance, seizures, and encephalopathy. So complication of TURP. So it, because of associated with irrigation fluid, that may lead to circulatory overload, hypothermia, TURP syndrome, and glycine toxicity associated with the position, that is lithotomy position, nerve damage, common peroneal nerve may be damaged if adequate padding is not done. Associated with the surgery because of bleeding, bladder perforation, and infections. So TURP syndrome is a classical triad. The patient will have a dilutional hyponatremia, fluid overload, glycine toxicity. So here the patient will have a encephalopathy seizures when the serum sodium concentration falls below 120 millimole per liter. And fluid overload may lead to pulmonary edema and cardiac failure. Glycine toxicity, the glycine is an inhibitory neurotransmitter that causes a depression of level of consciousness and visual impairment. So symptoms and signs, mainly the CNS symptoms and CVS symptoms. CNS symptoms, the patient will have disorientation, restlessness, confusion, agitation, drowsiness, and convulsion. Usually due to water intoxication and dilutional hyponatremia, hypoosmolality occurs. Blindness because of glycine toxicity usually recover within 24 hours. Cardiovascular symptoms, volume overload may lead to pulmonary congestion and cardiac arrest. This is because of a negative inotropic effect of hyponatremia. So under general anesthesia, all the symptoms of CNS will be masked. Only the presenting signs will be the rise and then fall in blood pressure and bradycardia. And the ECG may show a nodal rhythm, ST segment changes, U waves, and widening of QRS complex. And also the recovery from general anesthesia is usually delayed. So manifestation of hyponatremia, usually the patient will develop symptoms when the serum sodium concentration is less than 120 milliequivalent per liter. The CNS changes is confusion, restlessness, and serious hypotension, bradycardia. ECG is wide QRS complex. When the serum sodium falls below 115, somnolence and nausea, cardiac depression, bradycardia, the ECG shows wide QRS complex, elevated ST segment. When it is below 110, the seizures can occur, coma, and the serious changes is congestive cardiac failure and ventricular tachycardia and ventricular fibrillation. So management, first we have to ensure adequate oxygenation and circulatory support, and notify the surgeon to stop the surgery, and consider for invasive monitoring if the cardiovascular instability occurs. How to send for the serum osmolality, electrolytes, coagulation profile, and switch to normal saline for continuous bladder irrigations. So the irrigation fluid has to be warm. So the TURP syndrome can occur within 30 minutes of start of surgery up to 24 hours of surgery. So treatment of dilutional hyponatremia, here first line treatment is diuretics, 20 mg have to be given initially. So those on chronic diuretics, we have to escalate the dose to 40 mg. So the dose is titrated based on the response obtained from the initial 20 mg dose. Sodium correction is done in the formula desired sodium minus actual sodium into total body water. total body water 60% of body weight. So hypertonic saline, next to the diuretics, hypertonic saline, the patient has a seizures or cardiac dysfunction. So it has to be administered in the central line at the rate not more than 100 ml per hour. So how to calculate it? It's based on 2 times the total body water. So I calculate the total body water with the formula that is 0.6 into body weight, and 2 times the total body water is the number of milliliters of NaCl, that is 3% NS, that will rise the serum sodium by 1 millimole per liter. Next complication is hemolysis. Because we are using hypotonic saline, that may lead to hemoglobinemia, hemoglobinuria, anemia, and hyperkalemia. This has to be treated with diuretics and electrolyte corrections. So next major complication is the bleeding. The risk factors of bleeding is a large gland, extensive resection has been done, and coexisting infection, and duration of surgery is more than 3 hours. The absorption fluid, the bleeding will be more. So apart from this risk factors, the activation of plasminogen by urokinase, that is released with the prostatic tissues, may also cause fibrinolysis. Then may cause delayed post-operative bleeding. This has been treated with tranexamic acid, fibrinogen, and if needed, blood. So clinical features, the presenting symptoms will be tachycardia, hypertension, masked by bradycardia, and hypertension of overhydration syndrome. So roughly the bleeding is calculated 15 ml per gram of resected prostatic tissue, or 2.6 to 4.6 ml per minute of bleeding. So various methods for quantifying blood loss, such as radioactive labeling, RBCs, alterations, electrical conductivity, and calorimetric methods. Out of this, the true blood loss calculation using this formula. So we are collecting all the irrigant blood mixture and measures this hematocrit. So blood loss in ml is hemoglobin of blood in irrigation mixture multiplied by total amount of irrigation fluid used in this patient and patient's hemoglobin per liter. Using this formula, the rough calculation of blood loss can be calculated. Coming to the next complications of perforation, that may be intraperitoneal, extraperitoneal bladder perforation, urethral perforation, capsular or periprostatic extravasation. So patient will have, in regional anesthesia, there will be a patient will have abdomen pain or pain radiating the shoulder. There will be abdomen distension. Shock-like symptoms can occur, hypertension, bradycardia, and non-return of irrigation fluids. So in case of extraperitoneal bladder perforations is usually treated with the catheterization and antibiotics, whereas intraperitoneal perforations may need re-exploration. Coming to next one is a hypothermia. So in regional anesthesia, there is a redistribution of body heat, and also the area of block of regional anesthesia, the ability to shiver is lost. And also reduced thermoregulated capacity in elderly may further increase hypothermia, and use of cold IV fluids, irrigation fluids, and cold OT table and operating room will further exaggerate the hypothermia. So warm IV fluids has to be given to the patient, and warm blankets has to be provided. Coming to next is a sepsis. Bacteremia, patients will have an infected urinary tract that may enter the bloodstream and they are prone for infection, sepsis in immediate post-op period. So IV antibiotics has to be given immediately prior to surgery also. And the history of catheterization is important. That may increase, because of inflammation, there will be an increase in bleeding during surgery. Coming to pain management, mainly multimodal pain management, using buprenorphine patch or IV opioids. And catheter-related pain can be managed with lignocaine gel. Caudal epidural can be done, and pudendal nerve block using ultrasound can be done in these patients. So to conclude, the geriatric population have already decreased physiological reserve, and they have multiple comorbidities in also. The comprehensive geriatric assessment has to be done prior to any procedure, and pre-optimization has to be done in those patients, and early recognition and management of complications in the TURP surgery has to be done. So thank you.
Thank you, Dr. Ramadevi, for your wonderful talk. Except that small discontinuity, everything went all right. Regarding your topic, the preoperative evaluation is a must for the elderly patient. and you should be able to extract the history of the comorbid illness in the elderly patient. And we should ask the history of any drug intake for any hypertension, diabetes, bronchial asthma, and whether to tell them whether all the drugs to be continued or discontinued. According to the drug intake, you have to insect the patient. That is one thing. Next thing is, in your talk, one thing is new is the smartphone usage for the assessment of the geriatric patient. That is a good thing because nowadays the artificial intelligence is coming, so it will be a good pathway for that. And regarding the selection of the anesthesia, the anesthetic goal should be to achieve the best hemodynamic stability. That will be the ideal anesthetic goal to select the ideal type of anesthesia. And also the anesthesia level should be adequate blockade. And prevention and early recognition of TURP complication should be possible in your selection of anesthesia technique. So by considering all these things, spinal anesthesia with 2 ml of bupivacaine may be a good blockade without any disturbance in hemodynamic stability will be a good anesthetic technique. So in that we can recognize the regarding the complication of arising the complication of TURP and bladder perforation. That is also possible. And another regarding the usage of the agent, glycine is preferable because the visibility will be good with the glycine. So these are all with in Dr. Ramadevi's topic. And regarding the post-operative complication by Dr. Ashwini, the respiratory complication are more common in the geriatric anesthesia. Especially patient may be going for hypoxemia. So initially I told that the clothing volume is more than the FRC. So they are easily going for hypoxemia. So treatment will be the underlying cause and also oxygenate the patient and finally ventilation. So that will be the treatment for the respiratory complication. And regarding the cardiovascular system, the myocardial infarction is a major complication that may be occur in the postoperative period, and we should be alert and we should be able to resuscitate the patient. And also congestive cardiac failure, arrhythmias, so all the complication can occur and you should be ready to resuscitate everything. And another major involvement is CNS involvement. So postoperative cognitive dysfunction is another major problem in the geriatric anesthesia, and also postoperative delirium, and we should be able to tackle that. And another main problem is DVT. DVT also should be tackled very well. So in all these complications to treat underlying cause and oxygenate the patient. If necessary, you have to ventilate. So thank you all for patient hearing. And anybody who wants to ask for any clarification question, they can put it in the chat box. And meanwhile, yes.
No, already questions are in the chat box. They cannot directly put it.
Yes.
Already questions are there.
The first question
Yes.
from Dr. Muthukumar. Sir, elderly patients are having hard of hearing, and that make them look confused. Can we allow hearing aid into OT so that we can keep communicating? I think this question may go to Dr. Ramadevi. So as far as my knowledge goes, hearing aid should not be used in the OT. There are some electrical devices are in the hearing aid, so it may produce some electrical disturbances when you use a diathermy. Bipolar diathermy can be used. Unipolar is not advisable. So bipolar can be used, I think. And the next question.
Dr. Ramadevi, whether she...
Yes, sir. Yes, sir. Sir, regarding hearing aid, so properly we have to educate the patient regarding the procedure. We have to explain what goes on. So in order to avoid any anxiety. So before removing the hearing aid intraoperatively, it's better to take out. But prior to take, how to explain the patients regarding the procedure, what is the plan of anesthesia, how much it's going, that we have to explain and how to keep inside the theater. Better to have take out from the patient hearing aid.
Madam, you have to answer straight whether the hearing aids are allowed inside the OT or not. Yes or no? Moderator said no. I want you to answer. What is your opinion on that? Please allow me to talk on that. See, that
So
is...
you have to educate the surgeon also, not to use diathermy during a hearing aid.
Actually, that is an intelligent question. That is an intelligent question. That is a practical question he has asked. So permit me, sir, to have a few minutes. See, actually, hearing aids can be allowed inside the operation theater if the anesthetist feels the patient is tensed up. Because just like a pacemaker interference, because of the diathermy, it is not going to happen with this. That too, now the recently available these hearing aids will not create any problem. And if at all they are going to create problem, if you have an additional Bluetooth, then it will be a problem. But a patient cannot have same time Bluetooth and a hearing aid. So if the anesthetist has the Bluetooth, there may be a disturbance in the radio frequency and it will impair the hearing. It is not at all going to affect surgery because it is electronic equipment. But if the pacemaker is interfered with your diathermy, then the problem will be severe. That is not going to happen here. So now how we have to decide? If it is GA at the time of induction, this hearing aid can go. The patient need not have it in a GA. If it is regional anesthesia, then definitely you'll be tensed up. So we can allow, as the moderator said, we have to inform the surgeon that this is a thing possible. So patient is having that. But if you want to insert a hearing aid for the patient or the anesthetist or the surgeon, now patient right, we can take up the hearing aid. If surgeon and anesthetist, if they are using hearing aid, what we can do? So hearing aids can be allowed, but secure it firmly. It should not be slipped and it should not be dislocated while you are wearing a cap and mask. So that we have to be very careful. Practical points. While washing, you have to be very careful. Before entering the theater, you adjust the hearing aid and enter the theater if it is for the doctor. So I think with a little bit of precaution, it is not like a pacemaker, it could be used. Next, sir.
Okay, Dr. Muthu, again, Dr. Muthukumar, he has asked, sir, how do we identify TURP syndrome in given GA? Question goes to Ramadevi.
Yeah,
So in
yes,
spinal,
sir.
we can identify.
So in GA, so spinal, we can easily recognize by the CNS manifestation, whereas GA, all the central nervous system manifestation will be blocked. So in the ECG, there will be a wide QRS complex, and the patient will have a blood rise in BP followed by that is hypotension followed by hypertension followed by hypotension and bradycardia, and the ECG changes. And the recovery from the general anesthesia will also be delayed in the patients with the TURP.
Okay, no
so
other
CNS symptoms won't be there, will be masked, and the hemodynamic instability and ECG changes.
See, I think this is the final question. Dr. Meenakshi Sundaram, any other matter to be discussed here?
Hello, sir. No other questions, sir. So no other questions. So if you are ready, we can wind up with a vote of thanks. If you want to add up anything. as a winding up conclusion remarks.
Conclusion remarks. Anesthesia for elderly people as well as in the small neonate. So both extremes of life is very challenging. They may be easily going for hypoxia in neonate also and also elderly. So the answer is those who are going for the elderly patient surgery, they should be well versed with the physiological changes in the elderly. So what all Dr. Lavanya has told, they should be well versed with that. And the next thing is pre-anesthetic evaluation is that should be a very sound. So all the comorbidities should be extracted from the patient's history, and any drug intake, everything they have to they know, and they have to inject accordingly. And the third one, type selection of anesthesia. So these are all the very vital areas when you are going for anesthesia for elderly, and you should know about the post-operative complication. Post-operatively, hypoxemia is one of the major complication. You treat with oxygen, and if it's not responding, you have to go for ventilation. And post-operative disturbance in the cognitive dysfunction, and also post-operative delirium, where we should be aware of that patient may go for these complications. So these are all the things the anesthetist going for elderly people surgery. So thank you all. Thank you, Dr. Meenakshi, for giving us the chance to deliver lecture in geriatric anesthesia. Thank you, Dr. Ramadevi. Thank you, Dr. Lavanya, and thank you, Dr. Ashwini, and also all the viewers, audiences, and Dr. Muthukumar. He has asked a very two intelligent questions. Thank you, Dr. Muthukumar. Thank you. On over to Dr. Meenakshi.
Thank you, sir. Thank you.
Thank you for moderating the session, sir. We are happy that the topic geriatric anesthesia was dealt by young anesthesiologists from Velammal Medical College. So we thanks for that. We thank you. And to propose formal vote of thanks, we request our city branch treasurer, Dr. Hema.
Thank you, sir. Good evening. Good evening, everyone. I thank you all for your participation in today's episode on geriatric anesthesia.